Hi, everybody, and welcome back. We're doing an FAQ today about screening tools for PsA, SpA, and IBD. I'm your host, Audrey Gibson. Today, we're tackling an important but often overlooked part of patient care, screening tools. Specifically, which validated tools can help us identify potential psoriatic arthritis, spondyloarthritis, or inflammatory bowel disease, and when they should trigger a referral to rheumatology or gastroenterology. Let's dive in. We know that delayed diagnosis in PsA, SpA, or IBD can mean years of unnecessary pain, irreversible joint damage, and poor quality of life. But patients often first show up in primary care or dermatology and may not present with the textbook symptoms. That's where validated screening tools come in. They give us a structured way to recognize red flags and move patients toward the specialty sooner. For PsA, several tools have been validated, especially in dermatology clinics. PEST, Psoriasis Epidemiology Screening Tool, is just 5 simple questions about joint pain, stiffness, and swelling. A score of 3 or higher should prompt referral to rheumatology. Pearl, PsA, is newer, but is showing promise in broader population. Other tools, like PASE, exist, but PEST tends to be the most user-friendly and widely used. PEST is a great example of how a quick, patient-friendly questionnaire can flag PsA risk before joint damage sets in. When it comes to SpA, especially axial disease, we rely more on clinical screening criteria than formal questionnaires. The ASAS referral recommendations are particularly helpful. These say patients with chronic back pain starting before the age of 45 should be referred if they have features like inflammatory back pain, a positive family history, HLA-B27 positivity, or extra-articular symptoms like uveitis or psoriasis. In some primary care settings, tools like the Berlin or ASAS inflammatory back pain criteria are used to distinguish inflammatory back pain from mechanical pain. These check for features like morning stiffness, improvement with exercise, and nighttime pain. So the takeaway, if a younger patient has persistent back pain that behaves more like inflammation than a strain, that's your cue to consider SpA and to consider a referral. For IBD, screening is about sorting out functional GI complaints from red flags that suggest Crohn's or ulcerative colitis. Validated tools here include the CalProQuest questionnaire, which combines GI symptoms with stool calprotectin testing to improve specificity. More broadly, GI societies emphasize alarm features like persistent diarrhea, blood in the stool, unexplained weight loss, anemia, or extra-intestinal manifestations like arthritis or skin lesions. Patients with these red flags should be promptly referred to gastroenterology. So what's the big picture here? Use PEST in psoriasis patients to screen for psoriatic arthritis. Think ASAS referral criteria or inflammatory back pain features when you see a young patient with chronic back pain. And for GI complaints, remember CalProQuest and watch closely for red flag symptoms pointing to IBD. So these are some practical ways to shorten the diagnostic delay, get patients into the right specialist faster, and ultimately prevent long-term damage. And that's what matters most, making sure we don't miss the window to change the course of the disease. Thanks for joining me today. If you would like more information, please check us out on the WRAP website or the WRAP ACE app. Thanks.